Welcome to Rubin on Point, a podcast about cancer, resilience, and being human. I'm Dr. Dan Rubin, and together we'll uncover the true power of resilience, the strength to recover, adapt, and thrive through life's toughest challenges. Each episode will bring bold ideas, transformative practices, and inspiring stories that redefine what health, healing, and what the human spirit can achieve. And you're going to meet some really cool people along the way. If you're ready to turn obstacles into opportunities and live with greater purpose and courage, you're in the right place. Let's get started. Your journey to resilience begins now. Hi, everybody. Welcome to the Rubin on Point podcast. This is a podcast about cancer. It's a lot about resilience, and most of all, it's about being human. And there's really nothing more about being human than thinking about our brain and our thinking, our cognition, our emotions, anxieties, all the things that come along with that. And we're here today at the Serin Center in Scottsdale, Arizona, to talk to one of my favorite doctors and one of my doctors, Dr. Amy Serin, the founder of the Serin Center, the author of The Stress Switch, and a famous neuropsychologist. Today, Dr. Serin, I'm so happy that we can talk on this podcast and talk about what it is you do, how you help people, and what you've done for people in general.
Yeah, I'm so happy to be here. Thank you for having me. It's always a pleasure to see you.
Yeah, thank you. I know it's been a little while, but we've done so much work together. You've helped me so much personally, and because of that, I've been able to help so many other people by referring to you or just having knowledge in this realm, which, quite honestly, I knew was out there and I knew had value, but I didn't feel sophisticated enough to go reach for it and to incorporate it, amalgamate it into our practice, and now it is.
Yeah.
It's really an honor to be able to work with your center, and you see patients of ours, and what you've taught me, I pass on to people. And I think neuropsychology for some people could be a daunting word. Like, what do you mean a psychologist? Like, do I have something wrong or something? But referring somebody to a psychologist, or specifically a neurocognitive psychologist, means that maybe there's some balance that's needed in somebody's life, or people could even perform better. Like from an executive function perspective, I know I like to continue here just because I know it helps me perform and be better for my patients overall. Yeah. What are some of the things that you do at the Serin Center, and what are some of the things that are unique that people can find here?
I think that the unique part of what we do at Serin Center is that, I've had to have a lot of courage over the years, and not just kind of following the status quo of what's been done for 20 and 30 years and what's kind of out there that's been maybe used, but really in blending neuroscience with psychology and looking at things a little bit differently. When people say things like mental health, they think of something very nebulous, or, you have to make better choices, or you have to take this pill, or you have to do these things. And really, mental health is physical. Your brain is firing and wiring in ways that we can functionally see in real time. And this is the basis of how you feel, how you think, and all of your body's processes and what they're doing or not doing. So in thinking of it a little bit differently as, the mental being physical, we can be more precise and cutting edge with how we're looking at this and treating this. So we do things a little bit differently here, where we really blend cutting-edge neuroscience with psychology, and we make sure that we're measuring and treating. And what I mean by that is, a lot of times you'll go in and you'll talk to someone and they'll say, okay, we'll try this. And
what do you mean talk to somebody?
Go talk to someone like a psychiatrist or a psychologist, or even a medical doctor that will give supplements or something. And they're not closing the loop of measurement, of first of all, measuring where you are at baseline.
How do you measure?
Well, if we're talking about things like supplements, you measure with, blood work, right? When you're talking about neuroscience, you measure with brain maps, you measure with objective measurements, questionnaires and things like that have been scaled and normed, instead of just this subjective, like, well, how you doing with this? How's that going? Totally. And then I think I'm just going to do a little bit of this and a little bit of that. So I think that does make us unique, in that we're always closing the loop on making sure that what we're doing has high impact. We're very, very mindful about not only steering people towards the things that are going to work, what we think best, but away from things that aren't going to yield good results, because we see that a lot of practitioners like to just add and add and add, or do this and they're guessing.
Yeah.
And then they're sending people on these wild goose chases, and really we need to focus on what's going to have high impact and really make a huge difference. So the other thing is that we do things at home. We use transformational neurotechnology, which I've been very involved in. I'm on boards of several companies, and I've invented products and things like that. So really looking at a one-time purchase of technology that's going to change people's lives, that they can even use at home, and how that can really, really improve their lives.
We need to talk about that technology. But first, you wrote a book.
Yes.
It's called The Stress Switch. And I remember reading that, and it was incredible because it really put into context, and of course I have a medical background, so I could really dig in and understand the pathways, but it's helped a lot of my patients and put into context for us what the stress switch really is. What was the motivation for writing that book? And at the time when you wrote it, this seemed cutting edge and leading edge at the same time.
Yeah, so this was about 7 years ago that I wrote this book, and the reason is I was tasked with trying to help survivors of Ebola in Monrovia not get PTSD, or to fix their PTSD, and we could not get therapists to go out there. My thinking was, well, EMDR therapy, it's called eye movement desensitization and reprocessing, is one of the top trauma therapies. And they use bilateral stimulation in multiple forms. And I thought, well, what if I could extract that, like vitamin C from an orange, and could we deploy that out to these foreign countries and treat or prevent PTSD with the technology? And I had EEG equipment in my office, and so we started looking at
What's EEG?
It's an electroencephalogram equipment, and this is how we get people's brain maps. And so we took old wired technology that had been used in EMDR therapy for over 30 years, and I started looking at what it was doing real time in the brain. And it was pretty astonishing. And I thought, okay, I know that people have a physical sensation of calm when they use this kind of technology, but if it's this profoundly changing the brain in real time, like, why aren't we allowing people to have this outside of the clinician office? And this was the whole problem we started with, right? Is that we can't get therapists everywhere all the time. And even if you're in therapy and you're talking to someone 1 hour a week, what are you doing the rest of the time, right? There needs to be something that's helping your body and brain regulate in real time. So I invented the first wireless stress devices that use bilateral stimulation. And then people kept asking me, well, how does this work? How does this work? And I looked at the theories that were already out there, and I thought, none of these theories really explain what I'm seeing on an EEG. And so I figured out that the salience network in the brain, which this is the network that integrates all the senses. So your brain, we thought, used to be passive.
The salience network.
Salience, yes.
Salience.
Salience meaning like what's salient, what's important. It's actually a filter, but more than a filter, it's picking what you get to pay attention to, and also what's happening with your stress switch in real time. There was a great article that just came out in Wired magazine about this. There's an area called the thalamus in the brain that's part of this network. We used to think it was passive, but now we know it's kind of a master control center, because
we used to think it was just a pass-through.
It's very, very intelligent, turns out.
And it should be. I mean, we just didn't know it at the time, so we assumed maybe it's not doing anything.
Right. So with this assumption, what happens is people think, oh, I'm stressed out, I need to think my stress down, or I need to do something, but that's not really what's going on. We actually need to intervene in the salience network with sensory things, and that will
What are sensory things?
Well, in the stress technology, it's haptic microvibrations.
And so is this just the bilateral stimulation?
Bilateral stimulation of vibrations. There's something about the touch and tactile sense that actually downgrades the stress response faster than other things.
Does that happen in the thalamus?
Well, the thalamus is kind of the relay station that's taking in the sensory information, but there's also other areas of the sensory network that are deciding what to do with this. This is why if you are at a picnic having a great time and a couple ants bite you, you don't notice, because your thalamus and this network is deciding, hey, that's not salient right now. you're having a good time. We're not going to bother you with this, right? But if you're just walking quietly and a couple of ants bites you, you're going to notice right away.
That
It's
makes so much sense. That's such a
very
great
important to
example.
know that this is deciding for you. So when we add certain sensory inputs, your brain automatically, without conscious thought, will downgrade that response, which means we can hack this biological pathway in a really savvy way for the cost of like one therapy session. People can have this at their fingertips all the time.
So the device that you invented, I used them, and I have experience with them, and we use them for patients. And now you're on to the next version of it.
Yes.
But these are, they come out of the world of EMDR, is what you said. Could you explain how that came about, and maybe a little bit about EMDR and how that intervenes with the salience network?
So,
because people do know EMDR. Maybe you could, what it stands for again, and then for some people it's like, oh my God, that was really effective for me, and some people, oh, I tried that and it didn't work. And I know there's EMDR, and then there's other types of EMDR, and I really want to get into why testing and getting objective parameters is so important, and depends upon the skill and the techniques and the sort of cutting edgeness of the practitioner. But if we could talk about EMDR for a little bit, because I think you mentioned early on the term mental health. And that what we're talking about falls under mental health. I think the younger generations now are paying a lot more attention to mental health. And so I think EMDR is a big player in this, is it?
It is. In fact, it was just featured in The Simpsons a few months ago. It was just, featured in The Simpsons. And so it is hitting mainstream, finally. And it's really a superior therapy to some of the old ways that we were doing things. And one of the reasons why EMDR is so powerful is they're using bilateral stimulation. So it can be buzzing
Bilateral,
back and forth.
both sides
tactile.
of your body.
And this is the, both sides of your body. And it's alternating, so it's not going off at the same time.
And you're not doing it, so it's not like
And you're not
tapping.
doing it, So whenever I hear that EMDR didn't work for me, I say, well, how is a therapist doing EMDR? Because what happens is if the therapist is tapping someone, that does not get the same EEG response as when it's being done with vibrations in devices. We can see it in real time. It's hard to get the rhythm. It's also hard to tailor the exact frequency to someone because the therapist may slow down, may speed up. And it's also, when you're doing just the tactile bilateral stimulation, that tends to calm the nervous system down. But they add eye movements to that. That can be very activating. And if therapists are just using eye movements, but they're not using the tactile bilateral stimulation, then people can go into a flooded state. They can get very heightened in thinking about their trauma. And the effect of it does not happen as quickly as they get activated. So they leave feeling kind of out of sorts and then they don't like it. But when we have the tactile bilateral stimulation devices that people can take home, if they feel out of sorts because they've kind of stirred some things up, they can use those to help calm their nervous system until the next appointment.
Because of the salience network.
Yes, because of the salience network. And in session, we know what effects these have on the brain. I never do EMDR with just eye movements. I'm always using either the tactile bilateral stimulation, and we usually have it on the whole appointment because we're getting a nervous system calming effect. And then we add the eye movements for the actual, what we call trauma processing. So if therapists don't know what's really these mechanisms are in the brain and how they work, they may misapply some of the techniques of EMDR in a way that prolongs treatment for the clients or actually can cause an abreaction and people saying that was too much for me, I don't like it. And so that's what I find most often is the thing about when people say EMDR, didn't really work.
That makes sense. What does EMDR stand for again?
EMDR stands for eye movement desensitization and reprocessing. So we're desensitizing your trauma and we're reprocessing the memories so that they're more adaptive in your brain. So whenever you think about something that's happened, there's a heuristic your brain uses. Our brains are very, very good at using habits and patterns and things like that so that not everything is a one-off, right? This is how it conserves energy. The problem with that is that when we're dealing with things that bother us, right? And it doesn't have to be a huge trauma, like I almost died in a car accident or I was abused or something like that. This can just be something like, yeah, my friend said something and it was really upsetting and now I kind of don't want to talk to her when she calls, right? That is still ticking up our stress switch. So whenever we think of that, it's in a certain state and it comes out. Maybe it's a 7 out of 10 in disturbance. Maybe I feel it in my stomach. Maybe I feel like, I'm not good enough or I'm unworthy or there's some kind of identity thing that comes along with it. That's all clumped in together. If we pattern interrupt this, then the next time I think about it, it's not going to be a 7. It might be like a 3 or it may not be disturbing at all. And that's the magic of going through the salience network with this technology, because that, even without talking about it, trying to process your trauma, using those whenever you notice that you're upset actually creates a pattern interrupt, and that's the basis of all healing.
And then when you pattern interrupt, the person can reprocess that memory, and then you said like downsize it or downplay it, so the next time it comes up, it just isn't as impactful to them.
Yeah. So here's an interesting thing. So in EMDR, it's desensitization and reprocessing, right? If we desensitize a trauma, we can get it down to the point where you may not even need to reprocess it because it's just a little upsetting. So this is a power now that we can use using the technology and using techniques that are not full-blown therapy to help people function and help these things that are really bothersome feel very neutral without even therapy. So I like to call it lunch on Tuesday. In fact, I don't know, that might be my next book, we'll see. But we know we're over something when it feels like lunch on Tuesday.
Yeah.
If you think about lunch on Tuesday, unless it was amazing or really terrible, it's pretty neutral, right? Yeah. Pleasant, okay, good, whatever.
Lunch on Tuesday.
You can think of anything and have it feel like lunch on Tuesday. That's when you're really over things, right? And so that's what I really want to get across to people too, is we all have that experience where consciously we really want to be over something. Like, I want to be over it. I'm over it. I'm done with it. People will say that. I'm like, well, the way you're saying this tells me otherwise. I can tell your nervous system is like fired up and you're really not over it. I understand you want to be, but your nervous system isn't over it, even though you very much want to be. So we have to align those things, and we can do that over time with some of this technology.
I mean, that's fascinating. And like
really
you said,
cool.
There's some ways to maybe not do it as well. Are there ways that therapists could make mistakes using EMDR? Or is it maybe they just won't be as effective? And I liken it to the notion of homeopathy. It's sort of like you don't really make a mistake. I guess you could give somebody too high of a dose and they could go into approving, but a lot of times if the remedy doesn't work, it just doesn't work, but it doesn't cause harm.
Yeah.
Is EMDR like that at all?
EMDR, I see the mistakes or the EMDR not working well when therapists do one of two things. Number one is if therapists go into it too quickly with someone that's very traumatized, it can flood them. Especially if they're not using the bilateral stimulation tactile devices. And then I also see EMDR therapists be kind of afraid to go into reprocessing with people and spend a lot of time rapport building, a lot of time what they call resourcing before they actually get to it with patients that actually can handle the reprocessing. And also if the therapists know that they can use the tactile devices more often, they would not risk that flooding if maybe they've had an experience where that happened. And also using the wrong bilateral stimulation, just using eye movements without bilateral stimulation in the tactile form, or just using the bilateral stimulation in tactile form without using the eye movements. You can get people to a pretty neutral state with just the vibrational therapy, but you can't really reprocess a memory without the eye movements, in my opinion, and what I've seen over the last 20 years. So in not combining those two, maybe people aren't getting the whole treatment. Now, all therapy is helpful and it works. It's just, hey, could I have gotten a patient there much, much faster? Am I focused on the right thing? Am I giving them maximum relief? Am I really being efficient? Because this is a lot of time and a lot of money, and people are suffering more than they need to be. So I think as a profession, we really need to get more efficient and more neuroscience focused in terms of how we're treating people.
I agree.
Thank
and
you.
I come because you've educated me, your center's educated me. Okay, so talking about validity, legitimacy, and talking about when you say the profession as a whole, you mean all mental health practitioners, or do you mean neurocognitive psychologists or therapists or everybody who sort of practices in this realm? Number one. Number two, how important is it to combine, say, neurofeedback? That's a question. Definitely want to talk about neurofeedback, what it is it doing, how does it work, and what are the different types of neurofeedback? Because I know here, when I do neurofeedback, I have 19 different points of feedback that's going into your machine, and I have gel in my hair, and there's actually somebody sitting in there with me, and I can hear them typing. I mean, I don't know what they're typing, but I'm assuming that they're typing comments about how things are going and because of the feedback that's being given, and then also about brain mapping. So can we start with brain mapping and what it is and how it plays a role, why some of the treatments that people undergo may be deficient if they don't have their brain mapped, if that's true, and maybe take it from there, please.
Yeah, okay. So I think about the best way to explain this that people can resonate with is that game of whack-a-mole. Do you remember the carnivals with the game of whack-a-mole, right? So EMDR kind of takes these traumas and these things that bother you and these habits and patterns that are already there, and it's like moles sticking up, and we look at the targets and we whack them all. Now, that's great, but let's say someone has OCD or they're very anxious. I can whack all those moles, but the state of your brain dictates what happens with incoming information.
Okay.
So if I have an anxious brain at baseline and something happens, that's another mole. I actually need to unplug that machine. Otherwise, I'm going to spend my whole life whacking mole after mole after mole, and it's just going to keep happening. So one of the things that is, kind of a savvy, neuroscience way to look at this is, do I have a brain that's anxious at its baseline or that has another issue, and if I whack these moles, is that going to help with that thing, or is it going to come back in another form? And determining what that is. Now, most people in our culture are obsessed with chemicals and consciousness. In other words, thinking and doing and pills. So they think, oh, well, if someone's anxious, they should just take an antidepressant or do this or do that. But the brain is electro and chemical. And if we use things that are not chemically based to alter brain function in real time, or in the case of neurofeedback, to train the brain to be more efficient and then it stays more efficient, that oftentimes can get us a better result with fewer side effects than taking the chemicals. And oftentimes, Dan, people have come to me and they've tried these anyway. They've gone through the medication route. It's been years.
It's easy. It's quick.
Well, but it's not even really easy is the thing. Because some of these antidepressants, they take 4, 6, 8 weeks to titrate up. Then if they get side effects, they got to titrate them down. Then they got to try another thing. I mean, taking
a pill's easy, but maybe...
Taking a pill's easy, but the whole process really isn't.
Okay.
And also, a lot of the practitioners are guessing. They're not doing, genetic testing or getting EEGs, electroencephalograms before. So they don't even know what's going on in this person's body and brain.
That's what I'm talking about.
And it's not that they're not well-intentioned and brilliant and have done all this work and have all this knowledge of them, figuring this out. But everybody at the end of the day, it's a little idiopathic, meaning everybody is an individual, even though we have common. You have to test. You have to close the loop. So we're using electroencephalograms now as standalones to help psychiatrists and doctors doing medication to say, hey, this person has too much slow wave activity in their brain. If you give them this med that increases slow wave activity, here's what's going to happen, right? And the classic kind of thing is a kid that is with ADHD and they give them a stimulant and then it makes them incredibly irritable. Well, if they have too much slow wave activity and too much fast wave activity in their brain, it's like playing marionette where, okay, I've helped their ADHD, but now I've made them incredibly anxious. Or if I help their anxiety, now I've made their ADHD symptoms and their inattention worse. So we really want to be getting this data. So there's the measure.
So fragile.
I know it is,
so fragile.
Right?
And it's...
But we've got the technology and we have the knowledge. And so, let's use this. So there's a couple things with regard to the neurotechnology and neurofeedback, right? You can get an electroencephalogram.
Is that a QEEG? What is the Q?
Okay. The Q stands for quantitative. It's basically an electroencephalogram as we look at the raw data and how it's moving in real time. And that's the raw data of people's brains.
You put electrodes on the
Yeah.
brain and gel, and then they think, or what do they
Well,
do?
it doesn't matter what they're doing. We're just getting, it's kind of like if I'm measuring your EKG of your heart, I might want to measure it while you're exercising, but just at rest, I'm getting data
Okay.
of what it's doing and if there's dysfunction
I mean,
there.
you're always thinking, but
Yeah,
when you
right.
measure that, I mean, I remember when I got my first one, I just looked at your computer screen.
Yeah. And remember, consciousness is a tiny little network.
Okay.
Right? So there's all these other things that your brain is doing that we're reading in these networks in real
Is it
time.
mind-boggling to listen to you? Is that okay? Is mind-boggling a thing?
Maybe,
Yeah.
if it is for you,
But
sure.
I'm so happy we're talking about this because I, as a practitioner and as a patient, I see the importance of closing the loop and measuring the brain. Okay, so we have a QEEG,
So we have
quantitative meanings.
Quantitative meaning, we're taking this raw EEG, we're taking this raw data and we're filtering it through some kind of statistical analysis. It's so good now that we can get almost as precise as an fMRI, which is a very expensive test in the hospital setting.
Yeah.
We can do that in like
Functional MRI.
Yeah.
Okay.
We can do that in 45 minutes in an outpatient setting now.
Wow.
For a lot less expensive of a cost. So we can use statistics, we can use normative databases, which means we're comparing your brain activity to other healthy function. That's just like saying, okay, if I'm 5'4" and I have this bone structure, maybe I should weigh around 130 pounds, give or take. And now what's my weight compared to that, and how is that different, right? And then we want to move it into a healthy range if it's not a healthy range.
Normative values.
We look at that in your brain and how it's firing and wiring, and we know what healthy brain function looks like. So we're looking at brain function versus that, and we're coming up with, is this too much or is this too little? Is the brain overfiring, underfiring?
In certain areas,
How does
too,
it look?
right?
Yeah, and when the brain is firing and wiring a certain way in certain areas and certain key networks, we get predictable behavioral and cognitive and processing issues.
And you can read that.
I
You're
can
a
read that.
PhD neuropsychology. This is the other part, is being able to interpret it. The other important part is being able to do something about it.
Right.
Yeah.
So it's interesting because neurofeedback is maybe not being regulated in the way that I would like to see it be regulated.
Okay.
Because a lot of practitioners that really have not been trained in brain-based issues or don't have degrees in that or additional training can purchase like neurofeedback in a box kits, or they can do what they call an EEG, but they don't know how to interpret it.
That's it. Yeah, right.
I think when people are looking at maybe getting EEGs or neurofeedback, vetting the practitioner to see what their real expertise is. First of all, somebody actually have brain-based training in their training, right? Are they, if they're a master's level psychologist, let's say, or a licensed social worker, and they don't really get any brain-based training, or should they really be doing this if they're not board certified? Or if someone's a chiropractor and isn't board certified in neurofeedback, like what have they really learned about the brain?
But so they can have, somebody like that could have the neurofeedback in a kit. Actually, let's take a moment. What does that look like? Is that 19 lead? Is it 3 lead? Is it you press a button and go and the computer program runs and then what does that look like?
So the kits are interesting. It can be as simple for a practitioner to buy equipment from someone or lease equipment and then just be trained on how to apply it. But one question I would ask is, do you edit your own data? Because a lot of times then they'll send the data somewhere and then some computer will do it. And we know that what we call artifacting, editing the data is not quite as good yet as trained practitioners doing that. Because when you're taking an EEG, any eye blinks or any movements can be misconstrued as brain activity and not actually, real activity. So we're making the wrong conclusions. So someone sends that data out, they get a report back from a computer, and then they tell them kind of how to do this. And some of the neurofeedback is 2 leads. They might put 2 here, they might do 4 here. But I am really a fan of 19 channel, where you're really covering the entire head, because depending on what the issues are, most people don't just have issues in their frontal lobes. I know everybody likes to talk about frontal lobes, executive function, but really when we look at how the brain is networked,
I mean, it has to be. It's one thing. It's
if
like
you,
we're one body.
I mean, if you're just training frontal, you may get a good effect, but it a lot of times doesn't hold. It helps while you're training, but then we're not seeing the long-term effects. So I really like 19 channel, and I like something called Z-score, SW Loretta neurofeedback, and we don't need to get into all of that, but it's basically, instead of just, okay, I'm training delta from here to here and doing this, it's kind of like the difference between going to the gym and doing biceps curls or going to the gym and doing a HIIT training workout or an entire body workout. You're just getting more training. And the cool thing about neurofeedback is we're actually making the brain more efficient. So when it gets more efficient, it tends to stay more efficient if you've done it correctly. So the gains that we make in neurofeedback, we can sustain 95% of those if we've done that right, in years and years of time. So it's not like exercise where you have to keep doing it.
So when you talk about going to the gym and doing biceps versus HIIT, do you mean if you just keep going on a 2 or 3 or a 6 point, you're really only going to the gym and every day just doing biceps? It's not like one day triceps, one day biceps, versus the 19 point is the whole body all the time. Right. Okay, I just want to clarify that, because some people might be like, well, I do biceps, alone on one day.
Yeah,
but
sure.
Like, but you're not.
But that does one very specific thing, right? And that can be very helpful, right? But we're really looking at, if you're gonna go through the exercise, again, we're talking about efficiency, right? In treatment, if you're gonna go through the exercise of neurofeedback, like, let's do it right. Let's do it to where you don't need to come in for 80 or 100 sessions, right? Whatever we get, we know when the brain is stable, we know when the training has taken hold. It's kind of like braces where, you gotta have the teeth move and then you gotta leave them on and then you maybe have to use a retainer and then you're good. But if you take the braces off too quickly, things will move back. And then what a wasted exercise, right?
I liken this in medicine when you talked about how somebody may send the data off and then the computer reads it, but they don't understand that, blinking is, a different change. You need a human to interpret this, a skilled human. And I liken that, like sometimes when we do complete blood counts on patients and we do what's called a white blood cell differential to see what types of different white cells you have, well, the machine can judge those based on size. And certain people, like in chemotherapy or have certain immune issues or might be toxic, they might have the correct cells, but they may be read as a different cell because that correct cell is the size. So we ask for like an automated, instead of an automated, in a computer doing it, we ask for a human, a pathologist, to take a look at it. And we see the importance there.
Right.
You're getting that human judgment instead of, because it's subject to computer bias, I guess we could say. So I just want to reiterate, as a practitioner in medicine for many years and understanding what I've seen here and the importance of the QEEG and interpreting it as the gestalt for how you then deliver treatment. It's important because I do know I have been offered neurofeedback in other places where it is run by a computer and nobody's in the room. And I was and it wasn't done by first getting a QEEG. It was like, let's slap some things on your head and then click and then go. And it was covered by my insurance. I opted to not do that.
Yeah, well,
I came here, and I remember when, I do want to talk about some of the mechanisms of what neurofeedback's doing, because it's a common word, people talk about it. Very few people talk about the 19 channel. I now can talk about it, and I really push people in that way. Not everybody has that accessible in their location, because you can't do that virtually. I know there's some ways to do EMDR virtually, and we should probably talk about the benefits of that here too. But when I do neurofeedback, I sit and stare at a computer screen, and I try and get green chimes to come up on the computer screen, and that's a score, and I try and reach a certain score because then I could go to the next level. What is actually happening? Like, what is in the brain when you're just looking at a screen? You're training the brain, is what you said. Yes.
So if anyone's ever trained a dog, this is the way you can understand this, is this is operant conditioning. The dog has no idea what you're doing, right? But through a series of rewards that have to be very specific, well, hopefully, right? Well, I don't know, with AI now we'll figure out, like, the dogs have known what we were up to this whole time, right? And we're like, oh no. But as far as our current understanding goes, the dog doesn't know what we're doing. But through a series of rewards, we're shaping behavior. And so we're basically training the internal firing and wiring of the brain to be more efficient. And once it gets more efficient, it stays efficient typically. You've done it right. So we're not putting anything into the brain. This is not invasive. The cap scares people sometimes because they think, oh, what are you putting into my brain? Like, they get these visions of these old, 1950s movies where people are getting shock therapy and everything. And no, we're not putting anything into the brain. We're actually reading the brain's activity and rewarding the brain when it naturally fluctuates in a way that's more adaptive, healthy, efficient, and flexible. And then over time, that's when you're saying like clearing the levels, like when this gets better, then we redo the program. And you mentioned something really important, and that is, you got neurofeedback before we're offered where they just put you on a computer and leave. We're reading the brain's activity in real time as we're training, and that's really important because otherwise you can overtrain or waste time.
I've done that in running. I've overtrained.
Yes.
You get injured.
Yes, and so it's very important if you're shopping for neurofeedback to look at, is someone in the room, are they monitoring this? And unfortunately, there's some bait and switch going on in marketing where they'll say we do 19-channel neurofeedback, but they're doing a 19-channel brain map, but they're really only doing 2 or 4-channel neurofeedback.
Well, then how does that work well together?
Well, you could still, this is kind of the old style, and it's been used for a number of years, and it can be very effective for certain things.
Okay.
But it's just slower than the 19-channel. You need more sessions, and again, if you're not monitoring it, you can overtrain. So it's not, again, if I'm gonna go to the gym, I'm not just gonna walk on the treadmill on my cell phone. Like I'm gonna get something out of that visit, and I'm gonna do more.
So a couple things on that. One, you're based on efficiency. You want people getting well and then moving through. And that is indicated in your book because you present in the beginning a few cases. People are like, hey, this happened in 8 treatments. Got them better. Like it's amazing. Or 4 treatments or this. So it doesn't have to be drawn out and long and costly. Sometimes you can do things more efficiently the more skill you have.
Yeah.
So that brings me to the question of some of the devices that have either improved efficiency, one, which we have on the chair right here, which is the Dharma Doctors, because that's the bilateral haptic feedback that you were talking about being instrumental in inventing the first iteration. This is the second iteration, and I know you work with this company. I'd love to know more. And then can we talk about the helmet, because that has efficiency too. So what are these? How do they work?
So these are the Dharma Doctors, and they're an improvement over the first generation of the bilateral wireless stimulators that I did invent. And these are...
You did not invent these?
I did not invent these, no. I didn't invent these, but I am their chief clinical advisor because I love them. Yes. So you can use these with or without an app. They've got lots of things on their app and functionality and meditations and therapists and things like that. And you press 1 to control the speed. And this is the slow speed. You can see kind of how
the green is the slow
The green
speed.
is slow, and you can see how they're kind of vibrating back and forth. Yeah. And then the other one will control the intensity. So there's 3 speeds and 2 intensities, if not even using the app.
But the frequency at which those buzz and the duration at which they buzz, and that's scientifically vetted. Okay.
So in the beginning, when I was inventing the first ones, played with a lot of different frequencies and saw how the brain was changing in response to that in real time, right?
So
because again, we're closing the loop. So there were 3 that were sort of universal in terms of like 85–90% of the people are going to respond to one of these 3 with different intensities. And so I kind of took the best ones and put them in that, and that's what's in here. Now on the app of this though, you can get real precise with how fast and how slow. But in general, the one that's in the middle, this blue one, is about 60–70% of people, this will actually calm their stress.
Because, quickly, because I think it's 30 seconds or less.
So the published research on this technology is 62% stress reduction in 30 seconds and a 50% of pain or like somatic body sensation associated with that stress will reduce in 30 seconds.
Holding them.
In other words, if I think of something stressful, my stomach hurts, then, that'll get cut in half in about 30 seconds statistically.
I keep a set of these, in that case, charged on my desk when I'm seeing patients, and we bring them out, and works.
It does, and this is where, too, in terms of being efficient as a therapist, right? If I'm doing therapy, I want these in my patient's hands the first session while they're talking about things. I think it's not great that people come in with all their trauma and all the things that have been built up and bothering them, and for an hour they tell you about that, and then they just get in their car and go home, right? So we're getting some active treatment. The other thing that this does is it democratizes the use beyond the therapist's office. So if someone's an executive coach, for example, or if someone's a somatic coach or some kind of other practitioner, they can incorporate this technology into what they're doing and probably get much better results.
Wow.
Yeah.
And so what about during neurofeedback?
So we use these during neurofeedback. When kids are on the autism spectrum, a lot of times they have a hard time sitting still, and or if someone's really stressed out, we can use those during neurofeedback to get the brain to go in the right state. So think about that training the dog example. If you're trying to get a dog to shake its paw and it just never moves its paw for you to reward it, you got to kind of get it to do that, to start that process. And so we use those to enhance neurofeedback. And the other thing we use for neurofeedback to enhance it is sometimes we do neurostimulation before. It's gentle, near infrared or infrared light therapy.
On the brain.
On the brain to change the brain a little bit. Yes.
Transcranial photobiomodulation. Can we see it, and what is it called? So this is the NeuroMatrix helmet.
Yes.
I remember talking about it with you when you were helping to develop it. Well, you didn't develop the hardware, you helped to develop the frequencies and the programs that run on this.
Yeah, so my son, Connor, it was his idea to go with a matte black finish.
So cool.
And then my stepdaughter did the logo for NeuroMatrix. So it was like a family thing in terms of the design. But actually, Sanjay Manchanda, my colleague, we're going to be speaking about this, but he's the one that has pioneered the protocols for deep meditative states, near psychedelic states. We can get people into near psychedelic states with this. Yeah, when we layer things in.
What does it look like on the end? And those are red light LEDs at a wavelength of 1,070 nanometers?
Yes. Okay. Yep.
Why is that important?
So the nanometers is important because it, depending on the nanometer, it has different penetrance into tissue. So 1,070 has been shown to have deeper penetrance into the tissue. In other words, if we're putting it on our head, how far into the brain is this getting? And how much cerebral blood flow is going to be altered, and so what's the actual treatment effect? Some red light therapy devices are not very powerful.
They don't have the radiance to get through hair, through skull, through skin and skull, and into brain.
And the lights themselves are not that powerful, right? Now, also, this is near infrared. There are devices that are infrared, 810, 633, things like that, and they all have a different function. Most people are familiar now with the face masks that have red light therapy in them, and they have different things. 633 is for acne or skin tightening or this or that. They actually just have a little bit of a different treatment effect depending on what that is.
Different tissue types, different wavelengths, so the length of the wave, which is not the frequency.
No, the frequency of how we pulse it and how your brain responds, that's where the cutting edge protocols are important. And up until about a year ago, we really just had a couple of frequencies that were embedded in kind of out-of-the-box products, and now we can go from 0 hertz to 20,000 hertz and customize frequencies for people based on how their brain is functioning. It's just, it's like really cool. It's so huge.
A couple reasons this is huge. One, red light therapy is huge.
Yes.
But this is true red light, near-infrared photobiomodulation therapy specifically for the brain. But this can be dangerous in the wrong hands because you could use the wrong program. Not dangerous. I don't think nobody's going to die, but in terms of brainwave and functioning, and I think yes?
Yes, it can. So here's the danger in it, is that if you don't know what you're doing, because these are consumer products that anybody can just take out of the box and use however. There are pre-programmed in the hardware for this helmet some kind of generally safe to use protocols for people, right? And they're labeled appropriately. So, you don't want to use like Bright Mind or something right before you go to sleep. There's a sleep one. Use that before you go to sleep. So they're pretty intuitive. But, you can put the brain temporarily in the wrong state, and then that will create an issue. Just like if I take a medication that agitates me, and then I'm agitated for 6 hours, right?
But it'll cycle back to its baseline or to its homeostatic.
It will cycle back to the baseline, right? But you can do it wrong, basically.
Yeah.
So
But can people program them, like the consumer products, are they programmable by the consumer? Or are they locked?
This one is locked, except so we get an EEG or we take our best guess, and then we customize the programs for people, and then we have them follow up with us because we want to make sure they're using it correctly. We want to make sure that they're getting the effects that they want. And we've had really good effects. This also, red light therapy is being used quite a bit to prevent neurodegenerative diseases like Parkinson's and Alzheimer's and dementia. And I had someone who's 78 years old with Parkinson's that was using a red light therapy device with some success for a few years, and then switched to the NeuroMatrix. And within 4 days, the tremors had stopped.
That's amazing.
And he had more energy and was able to go and be more functional on vacation, do entire vacation days instead of half days, and generally had, a big effect. And so that's a good case because it's the comparison of this particular technology versus the red light therapy that was already out there that he was using diligently. But then if we go from nothing to this, it's incredibly powerful.
And so you're also using this during EMDR sessions, I understand?
Yes, we can use this during trauma processing. We know that we can get brain changes in real time. So when we add this to therapy, it can be incredibly powerful. We also can use it in the place of psychedelic trauma release protocols because the chemicals have an issue. Well, a lot of people are using psychedelics, right, for trauma release. And unfortunately, when we're doing the chemical thing, right, there's usually a side effect, or over time, we could be doing things that are harmful to the brain. We don't want the things that we're getting a good effect from to be harmful in the long run. Okay, it's like somebody drinking to help them go to sleep, but then they wake up at 3 a.m. and over time that's damaging to their brain, right? We want things that are cognitive preserving and cognitive enhancing and things that produce a powerful effect. So we want to be able to substitute things that have, quite honestly, very high rates of abreactions with the more non-invasive, safer technologies, and we can get the same effects.
Wow. This is cutting edge stuff.
Cutting edge stuff.
And the takeaways really are cutting edge. You have to close the loop. You have to have objective responses, be able to interpret the data and apply them to the person. And you can get an efficient and thorough treatment and improvement in your mental health.
Yeah.
I'd love to do a part 2 and see where we are next and look at some EEG changes. Would you be open to that?
Sure.
Yeah.
I'd love to do that.
Love it. Well,
always happy to see you.
Thanks for spending time.
Thank you.
And for Rubin on Point, take care.
Thank you for joining us on Rubin on Point, a podcast about cancer, resilience, and most of all, about being human. I hope today's conversation inspired you to see new possibilities for growth, healing, and strength in your life. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with someone who could use a little extra resilience in their day. Remember, no matter what challenges you're facing, resilience isn't just about bouncing back. It's about building a life of purpose, connection, and vitality. Until next time, stay strong, stay healthy, and take care of yourself and those around you.